Rancho Los Amigos scale. I put one of them in the chart when we had charts. I have one that's in the electronic medical record, that the Rancho Los Amigos gives us a sense if someone is unresponsive, they're Rancho 1, 2, or 3. As they're transferred to us, they may be confused and agitated, which would be a Rancho 3 or 4. If they are confused but not agitated, they may be a Rancho 4 or 5, and so forth. And as I said this morning, most of us are now Rancho 8, fully oriented and functional, or 9 or 10, which is intact completely without any sign of deficits. So generally speaking, we use a 1 through 8 scale, and I have those here if you want to look at it. It's not utilized as much as it used to be. One, we don't get as many traumatic brain injured patients as we used to get, and I think Fairlawn gets a lot of those. They're a little better at doing it than we are, and have an identified unit for the behavioral cases. We have our Wander Guard, which works in some cases, so we use the Rancho scale. Rancho Los Amigos is a large rehab hospital in Downey, California, and they were the ones that developed this back in the 70s, and so that's why they refer to it as the Rancho scale. It's a Rancho cognitive scale. So as people emerge from cognition, we expect certain behaviors, and there are time limits that tend to reflect those behaviors. And as recovery takes place, those behaviors often improve, and they are more adherent to what our limits are, what rules we set for them. So again, this is just sort of the overview of this slide, and it just goes on and on and on. In the early stages of recovery, some individuals emerge from coma and may have bizarre, unpredictable, again, the child dropping F-bombs, or whatever, the family member just doing things that one might not expect from a parent. Say a man with a brain injury, he's a painter and falls off a roof. We had a summer of men falling off roofs one year, and he's very impulsive. He's angry. And he's weeping at times, crying uncontrollably. And the family says, "My God, my father's never cried a day in his life." And look at him. What's going on? So again, you see some unpredictable and uninhibited behaviors. So during this time, we try to program behaviors. Again, it's important to imprint on patients during those times. Have a dedicated team that deals with them. Keep the environment controlled, and you will limit or delimit the breadth of the behaviors that you see. This is a wonderful slide. It's just too much to talk about. But the across the top, interventions for coma, emergent agitation, environmental controls, interventions, use the same staff. These are things that I've already mentioned. And education and research, we need to kind of educate our aides, educate the housekeeping people, educate the guy that vacuums the floor outside the room every single time you're in there with him. He's out there vacuuming, and it's terribly distracting, and on and on and on and on. So it's important. And then as the stability triangle, I feel like that you'll get something maybe about the stability triangle, but it just indicates that in all phases of medical recovery from traumatic brain injury, there is stability, and the interactions of these functions will either make a patient feel more stable, or be more stable, or less stable. And this is the medical stability. If they have pain, their sleep is terrible, if they're incontinent, vestibular issues, seizure issues, and it just kind of just goes on and on, the different medical things that we talked about yesterday, I believe. Then we go on with it's difficult to establish stability when these things are still problematic. The behavioral stability, the things we just finished talking about, imprinting on the patient, having a stable mood. If this mood instability, and there often is, that's gonna throw the stability of the entire program or this entire rehabilitation off. Again, and these are other problems that we observe for. I will say the elopement issue, we've over the years we've had people that actually have left the building, and on a couple occasions we've had to go out into the parking lot to help bring someone back in. We have a code for that where the patient is trying to escape, so they never use it. But they frequently will call me or somebody that can go out and perhaps de-escalate. We had one gentleman that went down Flanders Road. If you go out the front door to the left, and fell into a ditch down there where the land goes off, and so we went and got him and brought him back. We had one guy that lived down that way and made it all the way to his home and showed up, and sadly enough, we didn't even know he was missing at the time. His wife called and said, "Oh, hey, did you discharge him? He's home now." And so I and Paul Ligori and one of the outpatient nurse went over to the guy's house, and we wound up having to give him an intramuscular dose of Haldol to get him to calm down so that we could bring him back. That's a true story. That was back when Dr. Ligori was here every day. Now he's up at the other hospital, so he's the medical director at Bradford. And we had outpatient nursing, never now. So, but there was a man that was working as the outpatient nurse, and would check people in and take vital signs and so forth. So, so stability of behavior, that we want to really establish that early on, as we just talked about this morning. The definition of behavior within this treatment philosophy is including the cognitive stuff, the thinking, the saying, and doing. Yes, and so cognitive behavioral issues include these: memory, communication, and self-awareness, or in the instability of this limited self-awareness. Again, so we want to promote stable behavior. These are things that are indicative of a lack of stability in that triangle, the stability triangle. This is just a model. I don't know that it's all that important. I'm not sure that I've seen the stability triangle, but just be aware that there are three components of any triangle, and it includes medical and behavioral, and then the treatment plan, the active plan. And typically the active plan deals with the other two prongs of the triangle. So, one of the problems with the plan is that they have limited opportunities to engage in activity. It's going to destabilize your triangle going forward, your plan going forward. You want to give them plenty of activities. And remember the guy that said every day has 96 15-minute units. And unless we can give people activities to do in an organized and consistent way, they are going to be lacking at some point in their functioning, and that destabilizes the triangle. The team must explore obviously the abilities, interests, and need for support going forward, and in doing so, you reduce the risk of destabilizing or an unstable recovery triangle. So, ABA is excellent. I think I really admire the ABA techs, the technicians in the public schools, and we used to have a lot of kids that would come to the outpatient, and frequently I would get invited to see some of those kids, and the ultimate goal would be to go to their team meetings, and I would go, and occasionally we would get patients that are on the autistic spectrum, and so the ABA technicians look So you tell me if you're not hearing me, please. Look for the individual behaviors. They track those behaviors, and they try to understand the antecedents of those behaviors. So yelling, hitting, spitting, all those kinds of atypical behaviors. Again, we don't see this here in our hospital, but certainly in schools and in developmentally we can see those kinds of things. And so it's very good and important for the ABA technicians at the public school setting to get a better control over these people by analyzing the behavior. Excuse me. And so how they go about doing this is, well, those are the folks that do it, the psychologists, the educators, special ed teachers, and the behavioral specialists themselves. And there is a credential that you, in going through if you're an ed major, an education major, you want to be a teacher, you can take a credential in applied behavioral analysis. And I tell you, you can give them as complex a behavior and some of the clever and sophisticated behavioral plans, conditioning and counter-conditioning. These guys really do a beautiful job, and I am not a specialist in behavioral analysis, and so the plans that I come up with are fairly primitive, only because we don't have the means to really apply complex strategies to them. But these guys do, and sometimes they would train us how to proceed with the behavioral analysis. So he will look at he or she will look at the environment, the individual himself, which we've kind of talked about, and then whatever the target behaviors are. And I think we have to, well, we don't do exactly this, but we do need to think about target behaviors. They become part of our rehabilitation goals. And so target behaviors can be to reduce certain maladaptive behaviors, such as spitting, swearing, dropping F-bombs, lashing out, whatever that might be, refusing, and enhancing certain desired behaviors, having cooperative interactions and friendliness, etc., whatever the target behavior is. Participation in ADLs, getting a person to wash every day and shower once a day or once a week, whatever your typical goals would be. So again, discovering the variables, the ABCs of behavior, and that are very predictive of the maladaptive change, and we can predict things that would promote positive change. Now, sometimes people, and Dr. J does it all the time, he says you can't go into that room without spending 45 minutes. The person is so friendly and talkative and has that need to be kind of regarded and talk. So that's something you both want to build on and utilize as a reward, but also you want to kind of diminish that behavior so that you can get to work. Okay, so that you give them, say, what we're going to do, we've got things to do today, and here's what we want to do. We want to do ABC. Activity A, activity B, activity C. But let's talk first. I want to hear what happened, what you did over the weekend. Tell me what awesome stuff went on, and then we'll get right to work. So let's take 5 minutes and do that. So you're sort of setting the constraints to what you're allowing them to. Their need is to talk, but you can't spend 45 minutes. Your need is to get the therapy done, and so there's this kind of this sandwich technique that you use. Give them the chance to talk with a limit to it, and then okay, let's finish as we walk to the gym, and then you're talking. Okay, now it's time to stop. Boom, you get them doing what you want to do or what you need to get done and established in your treatment goals. So these three variables must be assessed. Indeed, I agree with that, and we got to take them. It's important. There are things within the individual now, so we'll go through this quickly that are going to impact how this entire thing works. The physical injuries they've sustained. Do they continue to have cognitive deficits? At what stage of recovery are they? Do they have any physical limitations, weight-bearing problems or weight bearing that they can't do? Is pain a significant barrier? On and on and on. The individual. The environment is, we know that. Is it overly stimulating? Some of those rooms, room 4, 5, 6, and 7, or 4, 5, and 6 are very noisy because the ventilator alarms are placed outside of those rooms. It's also the secretarial, the phone is ringing often outside the room. In the evening shift, one of the secretaries is laughing constantly, so you hear that, and patients have told me that it becomes difficult to concentrate when that happens, when they're laughing and talking. So the environment, we can control. We have some control over that. At times, patients will request being moved so they can either get a B bed against the window, or that the person that they're with is affected by the environment too much, or they are affecting this other person's environment by having their TV set on all night. And believe it or not, there are a lot of people that enjoy. There are more night owls, and they will watch television until 2 or 3 or 4 in the morning, and then get sleep. But things like light, noise, temperature, smell, other people in the room, these things all impact the cognitive set that you're trying to establish. And that's so important to understand. We're trying to establish a set, and that set might be ADLs. That set might be balance training. That set might be just getting in the tilt table or the standing frame and practicing standing. That set might be just getting from bed to chair or toilet transfer. Whatever that set is, anything that can be interrupted, whatever your goals are, and that's what I'm referring to as a set in this case, it can be affected by the people coming and going. And I feel like invariably when I'm in the middle of a memory test that the vacuum cleaner starts right outside the room, and it's all is lost. It's just not a good environment. So you target behaviors. That's the next part of the triangle. Behavior, I said be a better observer of behavior. By definition, behavior is anything that's objective and measurable, that you can see and count. Objective and measurable. And that you can count it in a consistent, every time he drops an F-bomb, you kind of make a hash mark. And we now, and that's during your therapy. I'll do it during my therapy. Speech can do it during their therapy. So we watch for certain target behaviors. And then we try to reduce those. And so what happens is we frequently get an increase in F-bomb behavior as we're trying to shape it. And then slowly the F-bomb dropping starts to drop itself. The utilization of that word, F, starts to be dropped. So what happens then, invariably, is people stop using the strategies that we've developed, and they say, okay, the problem is solved, and they stop doing the behavioral plan, and then the behavior returns, and then frequently the nurses will say, well, that's not working, it doesn't work, and we're not going to do it anymore. Well, it would work, it did work, and if you had stuck with it, it would have been better than what we have now. So it's harder then to target those behaviors and to reshape those behaviors, condition those behaviors after you've initially done so, and the rewards need to be re-established, and the reinforcers need to be changed. And I hope that makes sense or is understandable. So and here's what we do there. Why do you look at this? A, B, a C. Assess the behavior, collect data, and change the behavior. We did this with a few patients over the last couple of years, and really did get some significant downtrending in behavior. I'm trying to think of an example that we saw a significant drop-off. And then you actually don't need to do it, but you have a ceremonial switch so that you're imprinting on the patient that they've succeeded and have completed the task, and that here's a reward for completing the task, and we no longer have to do this. And that way you're kind of shifting the page on them, and then the data collection maybe changes to something else. So, and that's very important because you may have like a large data set to collect, and then when you print, you come down, this data is assessed, and the behaviors have changed a little, but then there's this small set of behaviors that you're going to also try to change to improve going forward. So then that becomes your antecedent, your assessment of the behavior you're observing, and you kind of work together to come up with another plan. So I hope that's clear. But so it's a reanalysis of the behaviors. Once you've changed the major problematic behavior, you go to more focused behavioral assessment and try to devise a plan for that. The functional analysis, targeted behavior, operationally defined. You want to say, okay, the F-bombs, that's how many times they drop an F-bomb, how many refusals they have, how many times they're off task and talking about their wife or girlfriend, and you have to redirect them. How many redirections are there? But specify the redirection itself. Sometimes it's all right to go tangentially off of task. Sometimes it's not all right to go off of task. Maybe even not using the call bell, and how many times do they get out of bed and take themselves to the bathroom a day, whatever the targeted behavior is. We have to operationalize it, bring it to life. That's what that refers to. Collect the data for 3 days at least, and then have some proactive shaping that takes place, consequence-based approaches. And obviously we cannot punish behaviors, but punishment is really the removal of a stimulus, a removal of a behavior, and that often then will shape it. We cannot apply some punishment to a behavior. Punishment is something that you do to the subject, whereas negative reinforcement is something that you take away from the subject, that we can do in some cases negative reinforcers. And one of which is you can sort of kind of turn away from the patient if the patient is being inappropriate. So and you might say, listen, I see that you're not quite ready for us to get started. Remember, we've talked about this. I'm going to give you a couple of minutes just to sit and think about this. You sort of take away your reinforcement, your kind, friendly outlook, and you sit silently. And I tell parents and family members to do this all the time. And if they continue to be inappropriate or aggressive or threatening or menacing, then just to get up and leave. Because, listen, honey, you call me names. I'm going to have to leave now because you've done this. And we've talked about how much that bothers me and hurts me, but you continue to do it, so I'm going to leave. I'll see you again tomorrow. Everything will be all right. Tomorrow will be a better day, and we'll do that. And that can sometimes shape that behavior, especially if someone has that need to have the visitors with them and so forth. The assessment methods are either direct or indirect. The functional assessment is, can they do the specific task that you're trying to get them to do? Are they able to do it and are just not doing it? Or are they, do they need to be trained on it? This happens a lot. So what we try to do is, if they can't do something that you operationalize, you break that task down into a series of steps, and then you practice and overlearn each individual step. So the task itself becomes a series of more simple and more easily integrated steps. And once they learn all the steps, then you can put it together and it becomes something that may work a little better for you. And when we talk about a functional assessment, is what is the behavior, how does it function for this person? How is his behavior? Is it avoidance? Remember we talked about that? Is it attention seeking? A lot of our patients require a lot of attention. They want to get attention. Sometimes these are the guys that maybe you're walking to the gym and they're making jokes or bringing attention to themselves as they walk by the secretary or the nurses that are working at the station or the doctors that are working at the station, and that becomes the operationalized behavior you're wanting to shape downward. Maybe they get distracted by these statements that they make, and they run the risk of falling down. So you say, well, let's try to walk without talking, because that interferes with your balance and your gait, things like that. What is the function of the behavior? Or what possibly may be the secondary gain, is what we frequently call. What is the secondary gain of this operationalized behavior that you're seeing? Yes. Right. I see that all the time. That people avoid everything I have to do with them, for the most part, often. And whether it's the psychological part of things, and they don't feel like talking about their early childhood or whatever the problems might be, the substance use, and so they jump the gun and start talking about the Bruins. But yes, they do it as an avoidance mechanism, and so but then you still have them though, Erica. They want to check a text message. Well, okay, check your message. I'll get my stuff ready, and we'll start right after that. Today we're going to do this. So if you can kind of, again, you've got this positive imprint, and I don't see how anybody, our staff are so kind and so intelligent and so attractive, and all the things that we look for in a staff, clever. There's no way that if this positive imprinting can take place, they're not going to say, well, screw you, I don't want to do the mocha today. I'd rather do, read my text messages. It's harder to say no to someone that you like and that you're attached to, that you've got this positive halo effect. And so you have to utilize that. Now remember, we talked about this. We have so many things now. The doctor wants me to do these memory tests. We have to practice them. So today what we're going to do is we're going to practice kind of the whole process of memory. And I can show you what it's like. Nobody does it perfectly. I can show you how to do this, and then we'll let you try it. You sort of use that kind of behavioral coaxing to get them to do what you want to do. And does it always work? No. Does it frequently work? Sometimes, but not necessarily. It sometimes works, because you're working against either someone that has a dementia who is sort of automatically now programmed to stay in the past and to talk about old things and tasks that they once did and jobs that they once had, and can't go forward because they don't have the cognitive, the capacity for encoding and consolidating new information. Or someone that's behavioral, that's emerging from this coma state or a near minimally conscious state, but now are well beyond that, and they're still wanting the attention. They're wanting to tell you about their how well they play baseball in college and whatever they do. So you can kind of negotiate that, and we have to be flexible. Not every session is going to be 100% what we want to do. Frequently it's not, and I think that we still need to give ourselves credit that we're working with this person. We have to be flexible and creative in how we assess, how we devise our treatment plans, so that they can accommodate some of those behaviors that are kind of stuck. Maybe these are the personality, pre-injury personality things that this person was very friendly and jovial and wanted to talk about the weather, and you've been there and done that with this guy, and now you want to get down to brass tacks and business. You have to find some way, and we've got to be a step or two ahead of them. So, and we can do that coming up with plans like that together as a team. This is the beauty of having folks that are dedicated to working with traumatic brain injury, is that they have things that work, that don't work, that you've never tried, and I might have something that I've tried and it doesn't work. So please help me with it, and I can help you with things that I've tried. So again, so yeah, Erica, you're absolutely right. This is what they do. The secondary gain is having you listen and smile and reward them that way for avoidance behavior. Avoidance is a tough one, because it's hard to, if someone has pain when they get up and walk, and you're wanting them to get up and walk, then it's going to be tough. They're going to want to avoid that, avoiding something that's uncomfortable. But again, but if they trust you, and if they understand that you'll give, quid pro quo, you give something, you get something, you give something, you get something, and say, listen, I understand you don't want to do this cognitive task, but let's do it, and then later we'll do something that you want to do. Again, quid pro quo. Sometimes that will help as well. And by now you know a lot about this person and what he's like and what his behavior might be symbolizing or might be searching for, and the tangentiality of it, you're able to figure out, okay, let's operationalize the behaviors, look at them, and what are the possible antecedents. And it may come down to as simple as, and what I do with people is I go in, I fly by. You fly by in the morning, say, listen, hey, I'm going to be back later on at noon or 12:30, right after lunch, and I've got some important things that we're going to do, and you maybe give them some sort of insight into what that is. We've got to do this today. I'm pretty sure you're not going to like it, but we can do it. And then you come back, and you do come back at that time, and you're not dropping it on him in the last minute. You're not kind of surprising him with your presence, and you kind of avoid that when the mule puts on the brakes and it doesn't want to go any further, they get stubborn, and you try to avoid it as much as possible. So I feel like the important part of this is operationalizing behavior. The behavior we operationalize avoidant behavior as something that's observable and measurable, and then in what context do these behaviors occur. I sometimes will be asked, should we change his therapist? And maybe you felt the urge to change therapists. Listen, I just can't work with this guy. Can you take him? Sometimes we generally suggest not doing that, as hard as that is, because it's going to be worse on the patient. It's going to feel like an abandonment, even though he may drop F-bombs and say, "You again? I can't stand your therapy. I don't want to do it." You're still have that imprinting, and you've got to work to find some way to kind of get that that imprinting more positive than negative.